Welcome back to our sessions at the Digital Health Society Summit. This session is on enhancing health data interoperability and learning from the US and from the European experience on the European Electronic Health Record Exchange format. This is fantastic to actually follow the discussion on the sharing data across continents and also addressing one of the key barriers identified during the previous session, the barrier for data sharing. Number one, no surprise, I think, was mentioned, interoperability. So I think we had a great discussion an hour ago, and we will follow up on that. This session will explore the business value of health data interoperability when the patient is given an active role with a focus on initiatives like blue button and yellow buttons. We will look on the potential to support innovative businesses and reduce barriers. We will hear from the colleagues from the US, where those initiatives are already in operations, already implemented, and see how we in Europe can learn from them. So today is a great day to look into US when all eyes are on you guys. And thank you so much for joining us from the US early hour for you. So in this discussion, this presentation, this debate, we'll look on some similarities and differences between US and EU and see how within the European regulatory framework, we can implement some of the learnings from the States. With me today, I have 5 speakers. I have Katrine Kronaki representing HL7 Europe, Luke Nicholas from EHTEL, Debbie Willis, mypatientlink.com, Vincent Cownan, Andaman 7, and Mark Roberts, Karin Alliance. So they all represent either a European perspective, like Katrine and Luke, Vincent running a company that operates both in Europe and in the US, and Debbie and Mark joining us from US. We will have 2 short presentations from Mark on setting the scene and history of the blue button, so learning about the blue button from the States. Then Katrine will give us an overview, how does it look in the Europe, and then we will engage in a debate, in a discussion. So welcome all again, and I will then pass to Mark to give us a bit of set the scene from the American perspective.
Sounds good. Thank you. I had some slides. Do you want me to share them on up there? All right, great. Just a quick background on the Karin Alliance. We are one of the 7 or 8 HL7 fire accelerators. We were one of the first 3. We represent about 70 different organizations within the US. This is just a quick cross hashing of all those that are part of the Alliance. We are focused only on the patient side of things. As you see here, our vision is to rapidly advance the ability for consumers and their authorized caregivers to get, use, and share the digital information when, where, and how they want to achieve their goals. Now, just a quick kind of background on sort of where we are in the US and how we've gotten there, and then also hopefully it provides or maybe illustrates some of the lessons that we've learned that maybe you all can take away from this. The work here in the US really is anchored on several major initiatives. As Carolina mentioned, the CMS Blue Button 2.0. There's several different rules in the US. The administration has the ability to promulgate regulation. So several of the rules that were finalized really had major impacts on that. So CMS is the Centers for Medicare and Medicaid in the US. They're one of the major administration wings that has the ability to really make those regulations. And so they passed or introduced a a final rule called the CMS Patient Access Rule. TEFCA, a Trusted Exchange Framework and Common Agreement, was another major one. And then the HTI-1 and HTI-2 are additional major pieces of regulation that have really had a major impact on sort of where we are in the US today. Many of these efforts were also accompanied by, as I mentioned, the fire accelerators. So the Cairn Alliance is one, Da Vinci is another that folks might have heard of, and among a number of other fire accelerators that have helped develop these APIs to help leverage different pieces of the healthcare network. So you have Cairn Alliance that did the patient access API. You have Da Vinci that was involved with payer and provider work as well. But let's start with the ACA really quickly, because that's where this all began back in 2010. Played a significant role in promoting the adoption of electronic healthcare records in the United States. And one of the key provisions was that mandated that healthcare providers switch from paper charts to electronic charts, emphasizing the need for HIPAA, the Health Insurance Portability and Accountability Act, to ensure the safety and privacy of electronic healthcare records in the United States. While the ACA did provide a lot of a big step towards data interoperability, they created a lot of other challenges. A lot of different data standards were created. There's a slow adoption of standard code language like FHIR, which is the Fast Healthcare Interoperability Resources. Sorry, there's a lot of acronyms in the U.S. healthcare system, as I'm sure there are in the EU. But suffice to say, as time has gone on, there's been a lot of efforts to try and improve the system and improve interoperability within the U.S. In 2018, CMS introduced Blue Button 2.0, which was an application programming interface API, so that individuals can securely access their Medicare Part A, B, and D data. Those are the types of Medicare coverage that you have, drug prescriptions, primary care treatment, and cost information. That was really a major step to giving patients access to that healthcare data that they might not have had access to previously. In 2018, right around when that was released, the Cairn Alliance published a memo to payers saying that we want to develop a platform to meet or exceed the capabilities of Blue Button 2.0 so that patients can actually get access to that data using a third-party app or an app that they're choosing. In 2019, CMS released a proposed rule that would require providers and payers to open up that patient data so that information would be made available beyond just CMS. And then later that year, the Cairn Alliance began developing an implementation guide. From here on out, you'll hear a lot of discussion about implementation guides in HL7. That is really the main method in the United States for how a lot of this work gets adopted and implemented. And so as I mentioned before, for patient access API, the Cairn Blue Button initiative built on the CMS Blue Button, which is why we called it Cairn Blue Button, to make that information available through FHIR. So we took the CMS data, we mapped it to FHIR, and created an implementation guide so that patients can access their health data from any app of their choosing. In 2020, CMS finalized that rule, which now required that providers and payers implement the standard APIs that allow patients to securely access, aggregate, and share that information. An important aspect of this as well is that while this was all occurring, we had a number of members come to us and discuss, well, what's going to happen with that data once it's shared? There's a lot of concern about nefarious actors and what third-party apps might do with it. They might sell your data. They might do other things with it. So we came together and we developed the Cairn Code of Conduct for consumer-facing applications. The code outlines how consumer apps should use, manage, and exchange personal identifiable health information to ensure that applications treat that health information responsibly, promoting trust and security in the digital health ecosystem. It's based on internationally recognized standards. It has been recommended as a best practice by the Office of the National Coordinator for Health IT, CMS, and TEFCA, and the TEFCA recognized coordinating entity. It's a free system. You don't have to pay for it. You just apply. There's a little bit of checking on sort of what you all do, and then there's a sign. You sort of sign on to it, and so it's something that it's really out there. You can go check it out on myhealth.com, myhealthapplication.com rather. There's a list of apps that are there, and anyone can join that as long as they agree to abide by the code of conduct. Earlier this year, CMS released another final rule, the interoperability and prior auth rule, which builds on that previous work that will improve data sharing and reduce burdens on payers, healthcare providers, and patients through enhancements to prior authorization practices in the U.S. So that's sort of on the CMS side. On the other side of the world is the Office of the National Coordinator for Health IT, now called also the Assistant Secretary for Technology Policy. They sort of added that to ASTP/ONC. They've been focused on TEFCA, as I mentioned, the Trusted Exchange Framework for in common agreement. It establishes a sort of a network of networks for data sharing across the U.S. to make it easier for payers, providers, and patients to get access to all that information. In addition to that, earlier this year, they published HTI-1 and HTI-2 to promote more cohesive approach to health IT. HTI-1 sets a foundational standard for data exchange and patient access. HTI-2 expands on this, incorporating advances in technology and tightening requirements for health IT developments to support interoperability and security. And these rules together really ensure that the health IT infrastructure keeps pace with regulatory changes and patient needs. In conclusion,
Mark, maybe we can move some things to the discussion as we for setting
sure,
the scene. I think, yeah. Thank you so much. So perhaps we could then, thanks for giving us this overview. And I think that the key elements here are that in the US, the blue button was established primarily to help share the data, the patient data with the insurers. And also we take the note of the caring code of conduct. I think it's great to also open a little bit more on that. But then I will move to Catherine to give us a bit of understanding what is happening right now in Europe and what is all about the yellow button.
Yep. I'm delighted to be in this session to discuss the XR initiative and also revisit the work that we have done more than, 15 years now, since the beginning of the Accountable Care Act with the US and the transatlantic collaboration. There are a lot of lessons to be learned, and that's one thing that I would like to mention in my brief presentation of this initiative. I'm supposed to be able to move the slides here. Yes, so in Europe, the big thing these days is a new regulation about data. This is the European Health Data Space, which is a health-specific ecosystem comprised of rules, common standards, and practices, infrastructures, and a governance framework. And under this umbrella, there are two infrastructures that are important. The first one is My Health at EU, which is about the cross-border exchange of prescriptions and patient summaries, and more data will be added, like labs and imaging and associated reports and hospital discharge letters. Where this regulation was released, we were challenged to put together a proposal about what's next, what else, what other types of innovations can you introduce. So we looked at the past and we looked at our vision for the future, and we said, yes, very much like what happened in the other side of the Atlantic, the patient are the key stakeholders. They have the skin in the game. They are the ones that care about their health data as much, in some cases, as the health system does. So our vision is that everyone can share their health data in the format, the European Electronic Health Record Exchange format, with the click of a button. And this format would be computable, so that you can have measures of quality and you can do something with this data. But what we have learned from many years in this area of interoperability is that you don't want to do something once. Sustainability is extremely important, and it is also related very closely to credibility in the industry, in the stakeholders at large. So we brought together 6 global standards organizations for sustainability, for the stewardship of the specifications. We brought the governments in under the umbrella of the Global Digital Health Partnership, which is currently led, at least the interoperability stream, by the Ministry of Health in the Netherlands. And then we brought the industry, because besides the partners, when we are talking about business, you need to have the business people there, because they will tell you what is credible, what's doable, what's actionable. So to implement this XR vision, we looked very much across the Atlantic. And we were inspired by the Blue Button, but we said maybe we should do things the way Europe does things. So we brought an outstanding consortium together, and we said we will focus on 3 things. The first is the button, very much inspired by the Blue Button, but it's less about claims and more about the data and the format of the European electronic health record exchange format. And the button, we envision that in apps, we envision that in websites. There, you click and you get your data. You see your data and you get them in a computable format that apps and software can use. The second is the hub, the mechanism by which the industry with the regulators and the standards organization can work together to accelerate adoption. This is taking a little bit of the US thoughts that underpin CARIN, the CARIN Alliance, and in general the HL7 fire accelerators to move things forward in realistic business-oriented use cases. And the last thing, instead of putting the labeling on the government, we are saying that the industry should act proactively and define their own add-on label about the format, about how the content would look like. So this is our project in a nutshell. I already mentioned the vision. Everyone can share their health data in the European electronic health record exchange format, in a computable format, at the click of a button. The other thing that we do is also something that is related to how things are moving across the Atlantic, as Mark said. We looked at 3 verticals: the XR button for data portability and the GDPR, the dashboards for public health and population health, and then clinical research. And we said, well, if these data look the same, maybe they should be coded and structured the same. So we are looking at the mechanism of a core element set, very much close to CDI, where these things would work in a cycle of PDCA. So you start with global standards, we move with business use cases, and hope we will discuss some of them in a bit. You test them in an experimental setting or a sandbox, then you move to live deployment and you provide feedback to global standards. But this is not only enough. If you want to do adoption, you need to monitor, you need to measure. So we have a whole work package about a monitoring framework. We have capacity building, cybersecurity, privacy, and of course, procurement. And we have also the business side of things, the analysis of the feasibility of the label. So this is our promotion of the yellow button, as opposed to the blue button that Mark talked to us about. And we are asking everyone if they are ready to face the challenges, if they are ready to face the patients and provide solutions that can be used by the patients. And of course, if they are ready to join us in the community of excellence to make things move faster. With that, I'd like to pass on the floor back to Carolina. Thank you.
Thank you so much, Katrina, and also for all of us, not only here in Europe, but all of us next week, we will have the European Electronic Health Record Exchange Format Expert Summit, and you all can join also online. It's on Wednesday, 13th of November. So this is just as a follow-up. Thanks so much, Mark and Katrine, for this overview. And I must admit that we started to think about this session and about this discussion during our Yellow Button campaign that we had in May and June. And then when we were collecting some ideas for the campaign, one of our colleagues wrote us the blue button was a failure. And then we were started to think, was it really a failure, or is it actually a success story that we can learn from? And now Katrine also said that ask business people, they will tell us what is doable, what is possible. So I'm looking here in Debbie and towards Debbie and Vincent. If you can tell us what lessons do you think we can learn from this US experience, and what we can bring to, what you would like us to bring to Europe? And was it a failure, or is there, like, what part of this blue button story is a success story? Debbie? I think you have to unmute yourself. If you just unmute.
All right. Thank you. Can you hear me?
Very well.
So I think it's unfortunate that the word blue button has been used for multiple things that do different things. And so the initial 2010 blue button was really basically a download of your data from your portal. You know, it was a little blue button on your portal. You could download it onto your PC. There was no standard format. You could, you know, the EHRs could do whatever they wanted. There was actually no standard content. So you didn't know if you were just going to get a medication list. And then through the years, Blue Button Plus, they had a standard format. I think that was a CCD. I think that was 2013. But during that time, that's when FHIR started bubbling up. It was developed in Australia. And then when the government became interested in it, we actually implemented FHIR. So the blue buttons that you're hearing of, the Blue Button 2.0 and the Karen Blue Button, what's different about them is they're not accessing data out of an EHR, which the first two blue buttons did. And they're not, you can't get like your lab values or anything like that. You can only get what was paid for. You know, these are the tests that were paid for. So I think there's a confusion of what the blue button really means. And when you ask if it was a failure, I don't think the new ones, Blue Button 2.0 or the Karen Blue Button, are failures by any means, because they use FHIR. The first two, it was just a beginning. So I wouldn't call it a failure. I call it a stepping stone. FHIR is the way, when we refer to it in the United States, we refer to the ability for patients to pull their data from an EHR. We call that the patient access FHIR API. We don't call it the blue button, because to us, blue button means payer data, which is very different than what a patient may want.
Okay. Thanks so much for this insight. And Vincent, I think you're also muted.
And I have to reach the button, sorry. Yeah.
This is how it works, yes.
Yes, I very much agree. Even if there was kind of a first blue button, which you've got access to probably many documents and unstructured information, it's still access to your information. So that was already a pretty good success, I believe, because in Europe, we don't have that. If I want to go to any hospital in Europe, I cannot even have, for example, a PDF of everything that was discussed, even if it's completely mixed up, right? Like the medications with the rest of the medical. That would already be a good step, right? Of course, Blue Button version 2, as sometimes they are called, is structured, and that's much better. And that's the next step, obviously. So that's very good. My view of the US, because to make everybody realize how hard it is in Europe and how late we are a Belgian company, so European company, right? And we build a software here in Europe, and then we try to connect to hospitals in Europe, and we try to connect to hospitals in the US. In the US, we have approximately 60,000 hospitals connected. And in Europe, just one. So you see how tough it is in Europe because the lack of the standards that we're working on, right? So what we do in Europe is very important, and we must move fast. And I think we must look at what the US have done. It was not an easy road, I know, right? But if I can make a very high-level summary for the US, I think there's been some kind of decision at some point to have a standard, which was FHIR. So I would say in Europe, we need to use a standard, and we need to use the same one. Let us use FHIR. Let us avoid ego stuff, right? And saying, yeah, in Europe, we're a bit different. We have different needs. No, we need to use FHIR first, and then maybe adapt it to privacy, which is a bit special in Europe. Maybe adapt it to languages, because we have more languages also. And we have social security. So there might be some changes, but it's going to be outside. The main thing should be FHIR. So FHIR, the technical standard, was imposed in the US, and then it was not sufficient. There has been some fights between the EPIC CEO and others, and the patient communities and the patient association, and they went to the government saying it doesn't work. And so there was a second step, like 2 years ago, I think, with financial fines coming up if the hospitals were not sharing data. So that has improved a lot, but it's still not 100%. I see patients saying, my hospital decided to be non-compliant, and they don't care, they will pay the financial fees, right? Which is shocking. But anyway, if there are financial fees and if they grow, I think at some point it will move everybody to the standards. Only these two things, technical and the mandatory aspect, made things really work for everybody.
All right. Thank you so much. And you already also touched on the patient participation and how does it look. Maybe I can ask Luke to give us a bit of also a view on that, like how we can ensure that we empower the patient to actually take an active role in this process.
Thank you, Carolina, and good afternoon, everybody, or good morning for the American citizens. There is one thing which I think is very important, is that basically the way we look at health systems, where basically in the US, for a number of reasons, the citizens need to be pretty much engaged because it costs a lot of money. So indeed, the way the blue button has been created is basically to support a business case, which was really important. So the engagement of people is recognized from start. In Europe, our systems have made, in a way, the citizens pretty passive because everything is organized for them. So they don't need to care. That's a granted right in Europe to have access to health. And that makes things a bit more difficult, in a way, to engage patients. But there is one tool, and Vincent, and I think Debbie also, are developing pieces of softwares which are directly targeted to the patient, to the citizen, with a PHR, so a personal health record, as a tool. And in Europe, what we've been missing, and I see it even in the European EEHRxF regulation proposal, where the right of access to data is fully recognized, that will be compulsory in all European countries. But the capacity for the patient to activate those data is not really elaborated in the proposal. So the role of the citizen, the patient as a key actor, still needs to be developed. What I see also really important to change is that in Europe, we have as many systems as we have member states, and in each member state, a very different level of maturity in terms of digital infrastructure, data sharing infrastructure. And this yellow button that we want to push will actually allow also to have alternatives, especially for countries where we don't have yet a capacity really to share and make those data available to patients. So that's also something which is really important to have in mind. It might still take years for some countries to have even a basic digital infrastructure. I have to say, but let's keep it for later.
Thank you so much. And I think that the companies that are represented here, like Adama 7 and also My Patient Link and so on, actually like provide the opportunities for patients, for the citizens to be more active in this area. I see that we have also a question from the audience. We have also the questions about learning more about the European Electronic Health Record Exchange format. And for that, I would actually guide you to the EEHRxF project website and then also to the summit that I mentioned before. You can also find the invitation to join online there about the role of some organizations in the project. But this is, of course, session hosted by the project, but it's not about the project only. So we want to talk about wider about the other issues. And the question is that, well, we've been talking about the interoperability for at least 20 years. And the question is, what is really needed to make data work efficiently for healthcare professionals and citizens? But I will connect it to the question I wanted to ask you also. So how can data interoperability initiatives activated by the citizen or by the healthcare professional unlock new businesses opportunities in the healthcare system, in the healthcare sector? Someone? Okay, Vincent. Yeah, Vincent and Debbie. Yeah, and then.
Well, there's new opportunities clearly, like if patients want to contribute to clinical research, they can bring a lot of the information. Today, clinical research is mainly done with hospitals and doctors, right? So that's the clinical evidence. And as the FDA is pushing, as the EMA is pushing, real-world evidence is needed more and more. So there's very clearly huge amounts of things that can be done on clinical research to make it sooner, faster, cheaper, but also reduce the cost of care, right? It's true for US and Europe. Let me give you a very simple example. I was tired one day. I went to my specialist doctor, and she said, okay, you will need a test, a blood test, and then we will have another consultation with the results, right? And I told her, but I have leukemia, so I already have tests every 3 months. Yes, but I don't have access to it, she said. And then I pulled up my Andaman 7 and said, I have the test. Take a look. She looked at the test and she said, okay, you have no problem with your thyroid. And so I immediately had the diagnosis, no need for a second blood test, no need for a second consultation. So huge cost reduction for the social security, an immediate response for me instead of waiting for 1 month. And voila, so that's if you multiply these by any number of unnecessary exams, that can be a huge cost saver. Sorry.
Sure. So
Yes,
yeah, showing also the value and the benefit for that. Debbie.
Yeah.
Yes, and I'll add to that. That was great what Vincent said. I agree with all of that. I really do think the future is that patients will be the custodians of their own data. They'll have their own little mini electronic medical record that follows them because we all travel and we need our data with us. The advantage of patients now having their own electronic medical record is that they can share it with whomever they want. We have a platform where our MyLinks consumer app is connected to another platform called My Research Link. So a patient can decide to share their data for specific research, for a specific time, and even specific elements. And I think that gives them the comfort that they can say what they want to share their data with and with whom and for how long. And also being able to share data with the FDA if there's an adverse event, something, they take a drug and something happens, well, they can send that over to the FDA. So this opens up the ability for patients to really engage in public health, engage in research, and also the ability in our platform, we can give the patient back all of their data, because a patient wants to join research because they want to get well, right? And so if all of my data is scattered somewhere else and down the road, I need that data, it's really important that patients get their data back. And so having the ability for patients not only to share their data, but to understand the impact of their data? What's the result of the trial overall? If I get cancer again in the future, I want to be able to tell my new doctors, these are the things we tried, so making this really patient-centered is our focus, to really engage the patient, give the patient what they want, and then they'll give you what you want.
Thank you. Catherine.
Yeah.
I would like to weigh in on that and highlight some pushback that we have received over the years, that patients are not ready for their data. And what I'm saying is that this has to happen for things to change and develop more what I call data literacy. And if we have the data there, we can have different conversations with the health professionals or the health professional team, conversations that are more data-driven, where you can compare and assess the impact of a therapy faster. And in the end, what this means is that innovative therapies can reach the patients faster because you have the data. You don't do it randomly. You do it because you have good quality data. So my message here, and I think we learned it from the US, and we have the opportunity to accelerate in Europe, is that aligning the stakeholders around data will have big impact on the services and their quality and paramountly patient safety. Thank you.
Thank you so much. I see, Luke, you have your hand up.
Thank you, Carolina. Yes, I think that basically we have the opportunity now with in Europe with the HLTH regulation and the formats, the EEHRxF formats, to create a new dynamic ecosystem. Of course, we have a number of use cases we already think about, but basically this is more than that. We now have the opportunity to provide the value chain with the capacity to invent continuously new use cases with the support of the patient. And that's what is really, really essential here. So we get out of the closed systems and we rely on three things. So a number of very clearly identified pieces of data. We rely on semantics, which are now more and more aligned, where the domains have begun to speak together. Before, clinical domain were knowing nothing of what was done in the research on the public health domain. Now, at least, there are initiatives to map what is currently used as much as possible and to reduce complexity. And finally, you still need the circle of trust in order to connect the value chain together so that you know that the people who want to access your data are reliable and can be trusted. So just to give a very short example, if we look today at the long COVID story, actually, the clinicians are pretty lost. They need to consolidate knowledge very quickly in order to know what to do with those patients. So they are really demanding to consolidate those data, and they make very extra efforts. Furthermore, our health systems are under constant pressure, and what we used to refer to quaternary prevention today is to say that the system is misused or not enough used for certain categories of people is becoming essential. And for that, we need the citizen and the patient to provide the data, because that's not the kind of data you get from EHR. There's other types of data that we need.
Thank you. I will let you, Vincent, to react, and then I have one more question before we finish.
Yeah, I think what is very important also is that there is an openness to the industry. By industry, I mean private companies, right? Because at least in Europe, the public funding is limited and it's already too low for the care we need, right? We know all health systems in every country are challenged by the population that is getting older and so on. So let us open everything a lot more to the private sector by having exchanges and by having standards, of course, with the privacy laws and everything that needs to be done to be correct. Because if we do that, then there's going to be a lot of private initiatives that will work, that put money into this, in addition to the public funding that we already have, and that they will develop new ways to exchange data or process the data, new ways to educate patients, new ways to monitor patients remotely, including AI to help doctors. And there's so much to innovate it. It will never be done by hospitals and public systems because it's too costly and there's no hope for return on investment, right? While if you have the private sector open up to that, that's going to help hugely. And that is what is happening in the US. So let's be very cautious about that.
Thank you so much. And I wanted, of course, the word trust came up, and we cannot speak about interoperability and health data without touching on that, at least in some way. But I would actually connect it with this openness to industry, what Vincent mentioned, and invite Mark to give us a bit of maybe glimpse into the code of conduct from Karin. Are the code of conducts like the one you developed a tool for supporting this building of trust? And then I will pass to Katrin, and I think we will need to finish the session.
Sure. Yeah, happy to. I just want to underscore one comment that was made earlier about using a common language like FHIR. I think all of this only works if you're using a common language like that. If you try and develop multiple different languages, things like the code of conduct and all this just fall apart. So I would highly encourage the EU look at whether it's FHIR or another language to use that as a standard code. In terms of the code of conduct, I think really the first piece, right, was developing the coming together as a community and developing a common methodology. How do you want to even develop this? That's sort of what we came together and did, and developed the code over a year or so. And again, the first phase is really foundational, right? Application developers self-attest to the principles of the care and code of conduct. Phase 2 is sort of disclosure. The app developer provides additional details on how they meet the principles of the code and self-attest to how they'll use it, manage and secure the health information. And the third phase, which is an optional phase, is validation. So multiple independent certifiers validate that they have self-attested to the questions, the app systems, processes, clinical guidelines, clinical decision support, et cetera. All three of those steps really help build some of that trust as they go forward. So hopefully that was a quick short summary.
Yeah, very good. Katrin.
Yes, this is another opportunity where we learn from each other. And indeed, we need a common language. But I'd like to also highlight that in XR, we focus more on the content rather than the exchange of information. So we would like to understand the shape of the data better and adjust it so that we focus on quality. And some of the elements of what Debbie said about adverse events is also at the core of the extensions that we plan for the IPS for research. Another point that I think is important, and you already raised it, is the code of conduct. And in XR, we are having a budget for new companies to engage with what we do and test it. And in that, as part of it is dedicated to CROs, that's clinical research organizations. And the EEHRxF code of conduct could be an interesting thing for collaboration. It was recently approved at the European level, and it will be a requirement for the companies that will work with us to abide to that code of conduct in use cases that relate, of course, to clinical research. The last thing I learned from Mark is the idea of having a registry of apps. And I think that we can continue the discussion and find out how we can create a transatlantic, perhaps, registry of apps that works with interoperability. Back to you, Carolina. Thank you so much.
Thank you all for joining us today. Thank you for taking time from your busy schedule and joining us for this quick session. And the next session will be on data governance, data governance model law. So I think we stay with the same thematics. Thank you all. Thank you, Debbie, Vincent, Katrin, Mark, and Luke. Bye.